At the outset, I thank organizing committee for giving me this wonderful opportunity. And as we know, as we are doing more endoscopy with more advanced techniques, when these nodules in stomach and stomach more common, and has been proven that these neuroendocrine tumors in the GI tract are rising exponentially, and in fact, in last 30 years, there is a 500% increase in the pickup rate of these neuroendocrine tumors. These incidents are not rare because we are more aware, we have better pathological identification, we have wider use of endoscopy, and of course, the PPI use may be associated with this. So the neuroendocrine tumor can involve any part of the body. Most of them are in the digestive system. We as a gastroenterologist deal with them. They can also involve the pulmonary function like trachea, bronchus, or lung, and also the gonads. So as a gastroenterologist, we have to deal with this, and the majority of the lesions are in small intestine, and we also find them in stomach, pancreas, appendix, and duodenum also. If you are working in a very high volume center and a center which has good, the backup of many specialists to treat this, your outcome is going to be very good. But if you are having very less number of experience on this, the patient may not do good. So one must be aware of these neuroendocrine tumor in the GI tract. How should we manage? If we see such things in our routine endoscopy, we must know. So the cell from where these neuroendocrine cells arise are ECL cell, either they can be histamine secreting or serotonin secreting. So these gastrointestinal neuroendocrine tumors are either called carcinoids or NETs. They can be gastrin dependent or gastrin independent. So this is very important. So once you see the neuroendocrine tumor, you take biopsy and then decide whether you are dealing with less aggressive tumors like G1, which has got mitotic index of less than 2 or Ki index of less than 3, versus poorly differentiated. These are very aggressive tumors which have got cellular polymorphism, and also the Ki index is very high, more than 20%. So we must know the organ of origin and the histopathology, whether we are dealing with G1, G2, or G3 tumors. So the diagnostic workup starts with staging, like the depth of infiltration, lymph node metastasis, that all determine the prognosis. So as soon as I see a gastric nodule, what I do is I see the gastrin. So if gastrin is high, that means these nodules in the stomach are being gastrin driven. Now, what happens is when there is a chlorhydria or less than pH is less, there is secondary hypergastrinemia leading to type 1 carcinoids, which I will show you how you see type 1 carcinoid. So whenever you see stomach nodules, divide them, whether you are dealing with type 1, type 2, or type 3. Type 1 are associated with atrophic gastritis, corpus predominant, leading to achlorhydria and high gastrin secretions. The second method of high gastrin secretion is if there is a tumor, like Zollinger-Ellison syndrome, when the tumor is being secreting a gastrin, which is causing these nodules to appear, and in this case, achlorhydria will not be there. In fact, there will be very low pH, and then these can be diagnosed as type 2 gastric carcinoid, which are associated with Zollinger-Ellison syndrome. But if you find the lesions are very big, like more than 2 centimeters, infiltrating into muscularis mucosa, there is angio invasion, or when you take biopsy, it is G3, you better predict that there can be metastasis, and they may require more advanced imaging like DOTA scan or PET scan to know whether metastasis is there or not. So first thing which I do is endosono to decide which layer are arising from. Mostly they are hypoechoic, and they arise from second layer or deep superficial submucosa. So this is the organ of origin of neuroendocrine tumor. And this is a typical endoscopy which I am doing to see endoscopy, the mucosa looks atrophic here, and then you have multiple such nodules. So this is a typical of autoimmune gastritis leading to corpus predominant atrophy, leading to hypergastrinemia, and leading to formation of these nodules. You can see once you do a magnification endoscopy in gastric corpus, you will find atrophic. So there is no collecting venules, there is no subepithelial capillary network, and this has been replaced by atrophic mucosa. So the background mucosa is showing atrophy, and then there are completely full of these nodules. So this is a typical of type 1 gastrinomas. So these type 1 gastrinomas, as I said, are associated with high gastrin. So if you see a gastric nodules, do a gastrin. If high gastrin, see whether the pH is low or high, or if there is atrophy or no. If there is pH of the gastric juice is high, that means alkaline, that means echlorhydria, you decide it's type 1. Type 1 are 70 to 85%. They are multiple, polypoidal, multicentric. They good prognosis. Prognosis is very good. You may not to remove all. I'll come to that. While type 2 gastrinoma, again, you will see high gastrin, but pH will be low because there is a tumor which is secreting the gastrin, and this is known as Zollinger-Ellison syndrome or MEN. While the tumor, if you find such tumor and the gastrin is normal, then it is a problem because these are rare and these are type 3 gastrinomas. Type 3 gastrinomas are more aggressive. They have got metastasis more than 50% at the time of diagnosis as compared to 2 to 5% in type 1. So majority of the cases are type 1 with good prognosis, while type 2, one must recognize them early with normal gastrin and should be referred for predominantly surgery, but we'll talk about that. There are no newer endoscopic treatment available. So type 1 majority are treated by EMR, and if they are more than 2 centimeter or they are muscular valve infiltration, they may require surgery. Other treatments like somatostatin, cytostatics, gastrin receptor antagonist are not considered in type 1, but may be considered in type 3 when you are not able to remove them endoscopically or surgically. So this is a typical of type 1 gastrinoma. Again, all are less than 1 centimeter. We are seen by endosono. You can see that tumor is arising from submucosa, muscle layer is intact. That means this patient is fit for ESD, and you can do a simple ESD and remove these tumors completely. So more than 2 centimeter you have removed by ESD, while the less than 1 centimeter, either you can follow them because the metastatic potential is so low that you may not require to do anything, but if required, you may do a procedure known as banding. You can see once we have removed this big tumor, you can band these small gastric nodules and leave them alone. So this is, they cause ischemic necrosis, and these small gastrinomas, gastric carcinoid falls down. So, but everything which can be removed should be removed. It's not like that. Type 1 gastrinomas are very good prognosis. Their survival rate is around 78 to 100%, which is not different from general population. Only those which are more than 1 to 2 centimeter also have low-grade malignant potential, low lymph node metastasis. So even if they are G1, they behave in a benign method, but if the lesion is growing in size, you may consider endoscopic resection. But even if you do endoscopic resection, there can be local recurrence. So it's important to consider the size and the histological grade. Like if they are G1, G2, small, you can treat by ESD, EMR, or full thickness resection. While if they are too big, they can be sent for wedge resections. Or the tumor histology is G3, again they go for surgery. But if tumor histology is G1 and G2, even if they are large, they can still be removed endoscopically. So it's important to consider the size and the tumor aggressiveness by initial biopsy. So these are some of the indications of surgery which I already talked about. The type 2 gastric neuroendocrine tumors are again hypergastrinemia, but they are associated with MEN syndrome. Their behavior is between type 1 and type 3. So majority of the time, their prognosis depends on the MEN1 rather than the tumor. So tumor will definitely can be removed, but again, they behave same as type 1. And these are the type 3 gastrinomas, solitary, not multiple, sporadic, non-gastrin, normal gastrin. So this is type 3, which is very aggressive. And we must say, if they are more than 2 centimeter, G3 variety, they requires a major surgery like subtotal gastrectomy. But if they are less than 2 centimeter, G1, G2, still you can consider endoscopic resection. Majority of them already have distant mets, may require systemic therapy or surgery, but be aware that type 3 gastrinomas are totally different than type 1 and 2, and the oncological resection is the standard of care in type 3 gastrinomas and may require other treatments like novel therapy, targeted radiotherapy, and so on. These are some of the other treatment which may be required, which I will not go into the details. So this is in a nutshell about gastrinomas. Divide them into type 3, type 1, and type 2. Type 3 usually will require systemic therapies, type 1 and type 2. And another thing important is that because type 1 and type 2 are gastrin dependent, even you can do a simple antrectomy to remove the source of gastrin, and they may have advantage if the lesions are too many to be removed. So these are some of the guidelines of gastric NET, depend on the number, the type of G1, G2, G3, and size. And again, once you remove them, they require surveillance at least annually or biannually, and they are type 2 are associated with MEN, so they require multidisciplinary approach. Type 3 requires more of oncological. So this was about stomach. What about duodenum? You see many duodenal polyps. These carcinoids are different variety. Most of them are non-functional. They can have a gastrinomas, somatostenomas. I'll not go into this busy slide, but summarize that there can be nodule in the duodenum which is gastrin producing, and if it is gastrin producing, it is more common, but they are more aggressive. So in duodenum, it is mandatory for us to remove all the duodenal NETs. There is less talk about doing surveillance as compared to type 1 gastrinomas. In duodenum, it is important to remove all of them because some of them can be very aggressive. The somatostenomas are mostly periampullary. So whenever we see a duodenal nodule, we must divide them, whether they are periampullary or non-periampullary. Periampullary are mostly somatostenomas, and they have higher risk of metastasis, and they require more aggressive surgeries rather than endoscopic removal. Non-functional duodenal NETs are also common, which can be easily removed. Poorly differentiated neuroendocrine cancers also behave like a cancer, and they can be removed by surgery. So once we have a non-functional neuroendocrine tumor less than 1 centimeter, we can do ESD or EMR. Between 1 to 2 centimeter, ESD mostly, and more than 2 centimeter, they require surgery. Surgery is also indicated when you have a poor histology like G3, or if the tumor is going beyond submucosa and invading muscle. This is a common variety when we see duodenum. They are full of such small tumors. You do a biopsy, they can come as neuroendocrine, non-functioning. We do banding of these tumors. This is known as endoscopic banding without resection. So you band them like a varices. They cut off the blood supply. After, you can do an incision biopsy to confirm the histology, but they can be left alone, and after surveillance endoscopy, you will find them, they are gone. So there are some small series about that. You have a full histology. If you want to cut them below the band, also is a possibility. Other methods of removal of these neuroendocrine tumor in duodenum, duodenal ESD is slightly difficult because the duodenal wall is very thin, and you can see around 2 centimeter a subepithelial nodule in D1, which can be, after endosono, if you see there is no muscle invasion, you can still do a careful ESD to remove these big nodules, which will be curative for these patients. Otherwise, they may require a major surgery. The idea is to have an en-bloc resection. The capsule should not be disturbed. You can see the tumor capsule there and the duodenal wall here, and there is a very thin submucosa. So the injection is required multiple times, and utmost requirement is once you completely dissect this out, you will require to close the mucosal incision because the duodenal wall is so thin. So we close preemptively the mucosal incision by loop and clip. And the histology is available, full capsule, and you can do chromogranin, synaptophysin. Ki index is important to determine whether you're G1, G2, G3. So if G1, capsule intact, so this is curative for this. Sometimes these tumors can invade the muscle. And still, if there's non-functioning G1 variety of tumors, you can do full thickness resection. You can see there is no, that this tumor has gone into the muscle. So you need a traction there. And then you can see there is no difference between muscle. There is no submucosa at all. And then you have to remove this tumor along with the muscle. So this is known as full thickness resection. So once you do full thickness resection, you have a complete removal along with full thickness opening. You can see the left kidney over there, and then you can just do a loop and clip method. Full thickness closure can be achieved, and the curative resection with endoscopic management of the perforation which was done. And this is a detachable loop which has changed our life. We can do more aggressive full thickness resection in the GI tract to get rid of these neuroendocrine tumor in the duodenum, which otherwise is very difficult to remove. This was about non-ampullary, but periampullary or ampullary lesions have high metastasis potential. So these patients require mostly Whipple's PD if they are more than 2 centimeter, or if they are G3, they require chemoradiotherapy. But once it's G1, you can still attempt to do endoscopic treatment, but aggressive follow-up is required in the form of a DOTA scan to assess the lymph node metastasis. Sometimes they are metastasized and they may require palliative treatment. I'll not go into the details, but to summarize that in duodenal NETs, one must take care of the thing that there is, whether they are ampullary or non-ampullary, whether their size is big. If the size is around more than 10 millimeters, many guidelines suggest direct surgery, but if the endoscopic treatments are available, as I've shown you, you can still go between 5 to 15 millimeter G1, G2 variety as a EMR or ESD. Even full thickness resections can be done. So I'll not confuse you more, but as I said, if your tumor histology is gastrinoma, they are more aggressive. Their lymph node involvement is 50 to 90%, and in these cases, we should better do aggressive surgery rather than endoscopic resections, because these patients with sporadic gastrinoma have high potential for metastasis, and surgery is the treatment of choice. Ultimately, I'll say that this requires a team approach, a good tumor board, including gastroenterologists, nuclear medicines, oncologists, all sit together to decide what is the best approach for these neuroendocrine tumors which are associated with major morbidity. But some of the neuroendocrine tumors are very, very easy to manage. They can just be surveillance, so it's important to have a proper diagnosis. But endoscopy plays a major role in diagnosis, removal, and palliation. Important to have a proper typing of gastric carcinoid. Not all carcinoids need removal. Majority can be surveillanced. Surgery is the main treatment for aggressive gastrinoids like type 3. Most duodenal carcinoids has to be removed, and there is limited role of chemotherapy except type 3 gastric carcinoid or G3 types of tumors which requires oncological care. Majority can be managed by endoscopic therapies. With this, I'll end my talk, and thank you very much for your patient hearing.